do, or is that almost always done by either the vendor or a consultant who has a lot of experience with that product?
Many of the EMRs exist today with front-end capacity to customize. So depending upon how savvy your organization is with technology and how interested you are in doing it yourself, making my screen as a provider different from the provider sitting next to me. A lot of the EMRs have very easy to use tools that allow that kind of change. Some of the changes will invariably have to be done on the client side, on the back end. Most EMRs, unfortunately, are not web-based yet. Especially the major vendors are more what they call client-server. So the dark backside is where a lot of the changes may need to be made.
Thank you. And jumping past Go Live for a moment, and then we'll come back.
Sure.
We've done this customization. The physician is using it, and the screen looks however it looks. Is that something that's frequently able to be changed after the fact for the physician?
That's really a matter of policy. Within your organization, I think it's important to set expectations about what we call, as consultants, change management up front. As part of the kickoff process would probably be a good opportunity to set expectations and say, okay, we're willing to give you your own order set after Go Live, but we're not going to change the way telephone encounters look.
Okay. And so we've now talked about the customization, and what would be the next step?
So after you've customized the system, you as the project manager has customized the system, you would want to take that customized system back to your stakeholders. And what could be a one-day validation session, or depending upon schedules and scope, it might be multiple days of validation.
And this validation does not entail real-life patients using the system. It's just making sure that it does what it is that everybody thinks it's doing.
Right. We generally try to offer a story or a scenario, a day in the life of a patient or a day in the life of a provider, and walk through what you are doing today on paper, walk through what that looks like in the EHR space post the decisions made during the design phase.
And the validation process would be a day or two?
Correct.
Is the office closed at that point in time? Is it done on a weekend? Or is it just done behind the scenes while the office is still open and patients are coming through in the paper world?
And that is really going to need to be determined by the organization and resources and schedules. And prioritization. Some provider practices make this a top priority, and I've seen them close down the offices to attend these sort of sessions. And others, it's a little bit more challenging, and they want the project manager to run the sessions after hours or early in the morning, and you kind of need to be flexible.
And so it seems like we must be getting close to having actual usage of the electronic health record. So what happens after the validation? After
the validation, very important pieces of the implementation: testing of the product and training of the product. The project lead would be responsible for walking through and essentially trying to break the system, oddball workflows, identifying any kind of bugs in advance of Go Live, especially those surrounding medications where they could present a patient safety issue.
And so, not to interrupt, but during all of those preceding portions where we've got the kickoff, the design, the customization, the validation, I'm understanding now that there's no actual physician and staff training of the software during those processes.
Correct. There's, I would call it continued demonstrations. So generally, providers and stakeholders will have a familiarity with the system, but might not necessarily know exactly how to use it.
Okay. Now, give us a typical scenario for training, if you would.
Sure.
How many days of training an individual person in the practice will need? How much time the trainers will be in the office?
Absolutely. So, and again, it's going to vary based on scope. Let's say, because I'm so biased in terms of Big Bang, rollout of the electronic medical record, and by Big Bang I mean determining in advance you want it all, and you go live with it all, and you go through the pain only once.
Flip the switch, and there you are.
Flip the switch, and you're there. In that scenario, I've generally seen about 8 hours of provider training, and I've seen it broken off into 2 separate afternoons. For smaller practices especially, it may be that you close the office for half a day and just get very hands-on and get busy with it, I guess.
And then you're going live, and do you recommend having a standard normal patient flow after that, or in most instances do you recommend sort of curtailing it a little bit and realizing that there will be some inefficiencies at the beginning?
I think expectation setting is important, recognizing that I've seen practices that have staffed an extra nurse for a day to help out with some things. I've seen bringing in 1 or 2 additional tech people to be there and assist with any questions providers might have for a week or so, or maybe less, depending upon your organization. Go live support, it's very frequently offered in the consulting world as well. But in general, I would recommend do what you do on a day-to-day basis within the context of the EMR.
I thank you for this very clear explanation. Having done over 30 implementation, I bet you've seen some phenomenal successes, and I'll ask you to talk about those in just a few moments. Can you tell us about some of the failures, and without mentioning any product names or facility names, tell us the types of things that have happened, and if you can, why they happened, where we ended up with an adverse event?
Right. Well, I did work at a certain hospital where the providers working in the ICU just refused to use the system.
And why was that? Do you think it was because they weren't engaged at the beginning? Do you think it was an inferior system that everybody knew was not likely to be functional?
I think it was because they were not engaged in the beginning, and I think it was because the level of executive sponsorship that is really imperative to the success of the adoption of the EMR was not present.
And what do you think could have been done early on to prevent a failure of that nature?
Had I been responsible for the inpatient aspect, the clinical documentation and orders aspect of that implementation, I would have held an ICU-specific design session where it really would have given the providers an opportunity to feel special, feel engaged, clarify their workflows, and develop a familiarity with the system.
Thank you. Any other failures come to mind as something to be worth noting?
I think the biggest failures that I've come across have been, they stem from the same place, and that's not engaging providers. Being very prescriptive from an IT perspective as far as what providers need, rather than listening to what they want.
Fair enough. Now let's talk about some of the successes and what types of benefits the physicians in particular, and then of course there are other stakeholders such as the insurance companies, the staff, the patients of course, get from a properly implemented EHR. But let's stick with the physicians. What type of benefits in successful implementations have you seen?
Absolutely. Well, the obvious is improved quality of care for the patients. Everything is now tracked, and you're able to provide much better care to the patient in terms of the system assisting you for conflicting medications or medication allergy interactions. I mean, I read a statistic recently that medication errors, adverse effects of medications is the number 5 cause of death in this country, and that needs to stop. So the EHR is an extremely helpful tool in that regard. I think what providers may not be aware of is as they grow more and more comfortable and familiar with the EHR, there's an opportunity to really show its return on investment. You're capturing a lot of data, and you're able to leverage that data in a number of ways to really show the financial benefits to your practice.
And are physicians able to see patients either more comprehensively, code at a higher level, see patients and document in a shorter period of time? Are there any time improvements from a physician standpoint in seeing patients with a proper implementation? Because we all heard hundreds of stories of the disasters where the physicians are seeing fewer patients, they're staying in the office later. And so tell us about some of the situations where physicians are actually able to see in a professional fashion a larger number of patients in the same amount of time.
Absolutely, and I will include the caveat that at the point of go live, you should expect it will be slow. You will, because it's unfamiliar. It's like learning anything. There's a curve. But once you master the EHR, you will find that your workflows improve in terms of time greatly. I gave you the example previously of a provider I spoke to recently who has cut down his dictation time from 10 minutes in total from dictating to using a combination of the EHR and Dragon to complete his documentation, and has gone from 10 minutes to 4 minutes.
Thank you, and I think you know I'm involved in Dragon and
Yes.
always love hearing things of that nature, but it can be very helpful. Tell us other situations where there's a particular additional technology, whether it be Dragon or something else, that facilitates the physician adoption of an EHR.
Sure. Well, I think a tool that I've seen is offered through many PACS vendors and independent archives of radiology and cardiology of that world, and that's a web viewer that integrates within the context of the EMR. So providers, general practice providers, don't have to go digging through films, or they don't have to go make a phone call and get an image from a PACS system from an ancillary hospital. Instead, all of this content is now readily available right in the context of where they're working.
And I thank you. And just to summarize, if you could rather briefly go through all of the steps from the beginning of the end, just sort of as a summary of what we've learned today, in just a few moments of what the steps are for a proper implementation, I'd really appreciate that.
Absolutely. So step number 1 is identifying your project manager. It might be a consultant, a savvy physician, or someone from the vendor themselves. The second step is project planning, scope identification, and that step goes hand in hand with setting up your kickoff meeting. The kickoff meeting is meant to serve as the transitional meeting between your sales vendor and your project team. The third step is your design sessions, system design. That's where you have the key stakeholders in the room and identify present practices and how they may translate into the EHR functionality. Following system design, we will want to build out and customize the EHR to meet the needs of your organization. After that has been accomplished, you want to get all of your stakeholders back in the room and validate all of the build and the decisions that you've made as the final sign-off. Following system validation, you'll want to set up testing and training for your EHR. Testing to make sure that there are no patient safety concerns or bugs in the software, and training so that your end users feel well equipped come day 1 of go live. And then finally, you're at go live, the starting line.
Rebecca, anything else that you'd like to add?
I don't think so.
Thank you very much.
Okay, thank you.
This is Dr. Eric Fishman from EHRtv, and we've been speaking with Rebecca Wiedmeyer, an implementation expert. Until next time, thank you.